Welcome, everyone. Thank you for joining us tonight. I'm Alyssa Eppel, and I'm part of the University of California Center for Climate, Health, and Equity, and help lead its Climate Mental Health Council. And it's really an amazing moment to be together. And we've only advertised this a couple days in advance, and we had over 600 professionals sign up. So you're all busy people joining this call to volunteer your time, learn something new, or freshen up your skills. Why are we here? The first reason is, as we've witnessed, 6 fires in Los Angeles have burned an area of 78 square miles. This is 1.5 times larger than the whole city of San Francisco. It's destroyed 16,000 structures, leading to tragic loss of life, human, animals, nature, and thousands of people deeply impacted in their lives emotionally and materially and physically. The risk is ongoing. As yesterday, we had a new fire in LA, the Hughes fire, now 14% contained, and today we have the Sepulveda fire, 0% contained. These events are unprecedented in their size, scope, and level of destruction. The health, social, and psychological sequelae that will become increasingly apparent in the next days and months. Our hearts go out to our brothers and sisters in Southern California. One of our sponsors is Jyoti Mishra on our Mental Health Council, who can't join us because now in San Diego, they are also on an evacuation notice in her area. So suffice it to say, we are clearly in tumultuous times with cascading events. The skills learned today are ever more relevant today and for our future. We have political change in our government administration that may increase the moral distress and injury when we face climate disasters. In addition, they've stated their intent to remove critical measures that reduce climate change, which provides the more dangerous climate context for worse and larger disasters. So, welcome. Welcome to being part of what we might call the Polycrisis Response Team. We are now a network. We have your emails. You can certainly opt out, but we would like to stay connected, and together we can help our communities, our local and distal California communities with climate change. You are all needed in this period that we're in. So I want to thank the team that planned this, the UC Climate Center for Health and Equity, the director Sherry Weiser and Ariane Tarani of UCSF, Annie Rosenthal, Claire Brindis, and our Climate Mental Health Council, Jyoti Mishra of UCSD and Philippe Golden of UC Davis, and Robin Cooper of UCSF. We are co-sponsored by the UCLA Center for Healthy Climate Solutions. In addition to this webinar, we've created a 6-series webinar on all aspects of coping with wildfires: health, psychological, social, and policy. So we'll put that link in the chat and you can sign up if you are interested in that series. And next, I'd like to introduce you to Dr. Robin Cooper, a volunteer faculty in psychiatry who co-founded the Climate Psychiatry Alliance and also years ago helped inspire us to form our UC Climate Initiative as well. Welcome, Robin.
Thanks a whole lot, Alyssa. As you've said, I wear several hats. One as the volunteer faculty in the Department of Psychiatry here at UCSF, and I am also the co-founder of Climate Psychiatry Alliance and the current president, which is a national group of psychiatrists, mostly, but also other mental health professionals and allies, and we're focused on education, advocacy, and response to the mental health aspects of the climate crisis. You can learn more about Climate Psychiatry Alliance on our website, and I'll put the link in the chat for anyone interested in that. But in this second career as a climate psychiatrist, something that I never planned I would be, I have built on my foundation as a clinician and educator and become somewhat of an expert in this exponentially growing field of climate psychology. But with the recent events in Los Angeles, so close to our home and many of us here, it's taught me some new lessons and brought the reality of climate disasters that I used to think were off in the distant future or in some distant, far off place that I did not know. Oh, how I felt safe holding that illusion. But that has been shattered. And I have learned a lesson I didn't want to know, that preparing for disasters that are multiplied by climate change cannot occur while the disasters unfold. We are so lucky to be here today in this group where we've been able to mobilize so quickly to fill some of the needed knowledge gaps and to have extraordinary guests teach us new skills in this emerging world we must get prepared to face. And back to you, Alyssa, to introduce them.
Thank you so much, Robin. And you can hear Robin Cooper and other experts, including Dr. April Naturale, on February 6th at our seminar. So we're just so grateful to have three deep experts in disaster mental health spend their time with us this evening. They have put together a very a full 2 hours, and they are extremely in demand. And to plan this, in the short run while they're helping so many communities in California with their disasters. Thank you. So first we have Dr. April Naturale, who is a traumatic stress specialist focused on response to disasters and mass violence. She provided disaster and traumatic stress response throughout the U.S., leading the New York mental health response to 9/11, the Boston Marathon bombing, and responding to over 40 natural disasters and shooting events. She helped with develop a crisis line, the 988 Suicide and Crisis Lifeline and Disaster Distress Helpline. Internationally, she's trained psychologists in Ukraine, humanitarian aid workers in Europe, as well as helped launch the European Center of Expertise for Victims of Terrorism. She is Vibrant's Emotional Health's Vice President for Disaster Services. We also have Dr. Sandra Koyfman, who is a psychiatrist with dual board certification in general adult psychiatry and addiction medicine. He is the CMO of Athena Psych, a New York startup focused on government programs. He served in a variety of clinical roles, restoring services in a number of community settings, and is an advisor to the APA Committee on Psychiatric Dimensions of Disasters. We also are lucky to have Dr. Grant Bremer. Dr. Brenner is a board-certified psychiatrist and a distinguished educator focusing on disaster mental health and trauma. He's an assistant clinical professor at Mount Sinai, Beth Israel, where he has taught and supervised for over 10 years. He's been long involved in disaster psychiatry outreach, DPO, which is now part of Vibrant Health. Thank you so much, the three of you, for the planning this training. We're going to have their slides afterward, and there will be a recording, and they will be involving you. So in the chat, and when you want to have your screen on, we welcome that too, to kind of see our community here. Thank you.
Mm-hmm. That would be great. Thank you so much, Dr. Appel and Dr. Cooper. It's a privilege really to be here with all of you. And we know that this is, as much as you're involved in being concerned about your community, that it's a lot to spend a couple of hours in the evening to try and get caught up on some of the updated best practices and hear what's going on the ground. So we appreciate your taking the time. There's nothing that makes us feel like we have accomplish something than being able to speak with our colleagues, share information, hear from you what's going on, and really have a sense that we're all in this together. So thank you again for taking the time. We'd love to get a sense of who's in the room. So if you wouldn't mind taking the time, you don't have to, of course, but if you can put in your name and your profession and what role you consider as your profession. If you're a climate psychologist, if you're a psychiatrist who is offering services to people with serious mental illness or work in the community, we'd love to get a sense of who's in the room. We're going to be talking about giving you really an overview of psychological first aid, which is the current best practice in disaster and immediate trauma response work. For years we had a black hole because there was no good research on what really works and helps people in the aftermath of a traumatic event who are suffering from acute traumatic stress rather than a diagnosable mental illness. And so our colleagues at the National Center for PTSD formed a working group back in 2005 and developed psychological first aid, which is an evidence-informed intervention that is well brought into the community and has been spread across the US as well as in Europe. There are variations like stress first aid, which is specifically for responders, and there's a fabulous variation for psychological first aid for schools, which can all be found on the website for the training that you can take online for free for 6 free CEUs, actually, and a certificate. But we're going to be giving you a really solid overview today. And as you heard Dr. Appel say, we welcome questions, comments that are relevant to what we're talking to today so that we can have a bit more of engagement. Thank you for filling the chat with who you are and your roles. This is wonderful to see. Let me say, too, on behalf of my colleagues and I, that we're terribly, terribly sorry to see this happening to your community, to those of you who've had losses and your loved ones who've had losses. This shouldn't be happening anywhere, and it is. And the best thing that we can do is come together and work together to try and move forward, figuring out a path for recovery, both emotionally and as we go forward, obviously, in many ways, especially looking at climate change and how we can work together globally to help each other get a handle on some of this. So again, we appreciate your being here and welcome your input as we move through the description of psychological first aid. Some of you may be familiar with this. If you aren't, I highly suggest that you take the full online training. It's about 6 hours, gives you a lot of good examples. But because we can see who you are in this chat, I suspect, and as we've heard from other groups who are psychiatrists, psychologists, people who've been in the field, healthcare workers who've dealt with COVID over the last couple of years, this is a group that I think will easily be able to absorb in the overview what psychological first aid really looks like in the field. The training online can give you more intense examples and some more details that might help you feel a little bit more competent with it. But I think when you walk away tonight, you'll have a good sense of what psychological first aid entails. I suspect many of you will be doing this, have been doing this already. We think it's a really nice structure that helps you to understand kind of from A to Z what it can look like. But I'm sure that you have many, many skills that you bring to this work already. There is some discussion about the fact that it's not all it doesn't all come naturally to us. And that's, again, another reason why we go through the 8 core actions to give you a sense of what the expert panel who put together psychological first aid offers as some of the most helpful ways of engaging with survivors after these acute traumatic events. Our goal is to de-escalate, basically, right? We want people to understand that they can recover from these things, but of course they're going to have some reactions that can be very, very disturbing and very distressing to them. So we want to make sure that they understand that with some good coping skills and good social supports, they can get onto a path of recovery. One thing that we like to bring into discussion for you too is to recognize that I know there's like 300 people on the call here, but not everybody is comfortable doing this kind of work. It can be really chaotic to be in the field. Environments can be unpredictable. This is probably one of the most unpredictable environments that I've ever seen in my 30-year career in responding to disasters. There are hot zones, literally popping up in different places across the state. And there are zones that are changing. They may have been safe at one time, and then there is another fire and it gets reignited and it's turned into a hot or an unsafe zone again. And that can be really scary when you're on the ground. Another really important thing to do is to be able to think quickly, to do a rapid assessment of where do I need to be at the time. And as many of you know, we look at the timing of interventions. We have so many people who call us on the first day of a disaster and say, I'm ready to go in. And that's usually not, appropriate until we get a sense of what's going on the ground. And so we always look to connect with the local folks to see what's happening on the ground, what's really needed, where are the gaps. And we want to make sure that people can tolerate intense distress and different reactions. There can be distressing scenes, there can be gore, and there can be sounds and screams and cries that are difficult to manage. It's really important for us as professionals to say, do I feel comfortable doing that? Is that something that I can tolerate? And can I contain my own emotions so that I am modeling calm and stability and grounding when I go into the field? And it's okay if you say to yourself at that time, you know what? Not this time. I can't do it this time. And obviously, there are some guidelines around that, especially if people have had a number of traumatic events or a serious traumatic event in the year prior to thinking about going into the field. And for those of you who may have experienced loss yourself in these particular fires, it may be that it's smarter for you not to respond or to find a way to support your colleagues, maybe from a few steps back rather than being in the field yourselves. It would be like you're not being a human being if you don't respond to something that's going on in your own community. So we ask people to think about that very, very strongly as to whether this is a time and an event that's appropriate for you to respond to in an intense way or not. We could do a whole nother discussion on working with diverse cultures, ethnic groups. One of the things that we try to teach people is like, this is not the time to get into an advocacy role or to decide to stand strong on beliefs and argue with survivors. In different cultures, you will see things that you might not be comfortable with, whether it's having to go and speak to a man before talking to a woman in the family, or having to go to an elder before you enter a community. If that's what the culture demands, then that's what we respond to. Otherwise, it would be very difficult really to engage with people. We highly recommend that people have a sense of talking to the locals, those who are leaders and those who are not really the leaders, but the ones who know more information about the particular culture to help you understand where is it appropriate to enter and how to do so. What's people's understanding of a disaster, of health, of mental health and mental illness, as well as what's their experience with the government, which is a very significant issue in the past decade and certainly more recently in the past couple of years. And the other thing is, we've never been good in this field about attending to self-care. People roll their eyes. I'm sure a few people have done that when I say the word self-care and think, I'm a responder. I'm fine. This is not for me. We have seen, and as recently as last year, when we were sending people into the field, we've seen psychiatrists, psychologists, therapists who are very well respected, who are highly functional, highly educated, and who do a very good job, have successful careers and work well with patients, have trouble in the field and need to be pulled out because they're not doing self-care. And we'll talk a little bit more about that later on. So you have to have the capacity to be able to do that. If you're not managing in the field, it's going to be a problem. And it's going to affect everybody else around you and how you respond. So we do train folks to engage in self-care, but you also have to have the capacity to know and accept that this is something you need to do when you're in the field. So think about the requirements. I'm going to turn it over to Dr. Koyfman to talk about some of the basic assumptions of psychological first aid.
Thank
Sander.
you. Thank you, April. And I think it's important to mention in our intros and how we think of ourselves. I realized one title amongst many that I haven't included and really should have was being a battle buddy to Dr. Brenner, and Dr. Brenner being my battle buddy. We do vast majority of our responses together or continuously communicate with each other when we're engaged in a disaster response. And that has been absolutely essential to us not only becoming really good friends, but also just really knowing that there is someone who's watching your back, someone who's there for you and understands what you may be encountering, how you may be dealing. And I'm just so delighted to have this sort of relationship in this high tension, high demand, personally taxing often work that we do. And of course, wanted to give the same kudos to April, who seems to be everyone's battle buddy. So thank you for just making sure that we remember that this is an essential part of responding to communities, is building your own community. So we really need to emphasize that point. The other thing that I also wanted to add, when we think about cultures, we also have to think about the political and political cultures. This increasingly makes our communities divided, but what we're really talking about is making sure that post-disaster help reaches everyone, and finding that space where you can suspend the disbelief and work with communities that may believe very different things is really an essential part of the work that we do. One thing that I wanted to say out loud as well is that for very many of you, none of the content that we're going to talk about is going to be new. And we understand it and we appreciate that there is enormous amount of expertise in the room. And we really thank you for being here, but also thank you for being part of this community, making your comments visible in the chat link, having your name out there really helps folks to know that there are experts in their own community that they can reach out to. But we also hope that having this conversation helps to bring us back to the professional environment and setting where we can learn rather than only focus on direct response. Taking that pause, thinking about what underpins your ability to engage in the field is useful and important. And having the teaching sessions, if you find this slide deck useful, please let us know and we're happy to share and make sure that you can continue doing your work instead of wasting time trying to reinvent the wheel and trying to come up with new content. We're more than happy to share. So when we engage and we think about, so that really goes to that first point, that anyone can learn the basics of psychological first aid, and we want to make sure people do. We want to make sure that we think in terms of using the language that works for the communities that we engage with, and not just verbal, but nonverbal communications. Grant and I had an amazing privilege of working with Afghan evacuees a few years back, where one of the key first things that we spend time learning is simply how to say hello. And making that effort makes a huge difference in how you're received and how you're able to engage. Getting it somewhat wrong, but trying is better than not trying. So that really is appreciated, and making that visible effort makes a big difference when folks are in distress and are able to process only so many cues in the amount of time that they have given you. So try to engage in a way that is familiar and comforting. Of course, it goes without saying that emotional distress is not mental illness. It is not the time to start diagnosing. It is time to inquire and know what the person has lived with and through, and what kind of lived experience they may have. But it is not the time to start coming up with sophisticated, complex diagnosis. It is, how do you cope with right here, right now? What sort of tools do I have? I'll never forget how I approached someone in 9/11 response, and being a green second-year resident, tried to do more of a traditional, how are you doing? And the young woman turned to me and said, how do you think I'm doing when I have no access to my house, my children and my husband are in the hospital, and all I need from you right now is take me where the clothes are so I can get enough clothes so we have something to wear in the hotel. I shut up and I walked her to the pile of clothes and did what I had to do. And that was the most meaningful emotional health intervention I could think of, and was the right one. So don't worry about getting it not to be what you're used to. That's really the point. Do what the right thing is for the moment. Follow your gut, engage with colleagues, and if you're doing something wrong, make sure you have a battle buddy who's going to tap you out and make sure you take a breath and have a moment to take care of yourself. Access natural, social coping, and recovery tools. Remember that there are members of the community who have lived through this before. Those members of the community normally would be thought of more vulnerable. Those members of the community that everyone's going to think, well, you know, grandma really needs help. Let's make sure she's sitting here comfortably. Grandma may have important stories to tell, and stories of recovery and stories of coping, and really thinking in terms of who is the head of the community in front of you, the family in front of you, the group in front of you, really can make a big difference in how you're able to engage. We think in terms of distress reactions that are common and very much expected. We also need to appreciate that doing all these things that psychological first aid proposes is not necessarily going to lead to an immediate relief, but not doing them may actually worsen distress. So it's worth doing even if you don't see an immediate result. So you want to understand that the focus is on stopping the flood. If someone is overwhelmed, limiting the conversation by simply turning the person away. If they're looking at the TV where the images of the fire are being replayed over and over, pulling them toward the food station and giving them a bottle of water may be all you have to do. So really being aware and cognizant of your environment is incredibly important. What we expect, of course, are any number of things that we know we ourselves go through when we're in distress, from sleep problems to being sad, fatigued, angered, or really having very high energy and overdoing it, over-engaging, which can put the person in danger, make it less likely that they're going to be able to take care of the home front, may make it particularly difficult for them. So find a way to give them an off-ramp. Ask them to help you carry the bottled water to those who need relief. They will feel that they are doing something meaningful, and they may be able to disengage from a frantic activity that they may be engaged in otherwise. When someone starts talking about the intrusive images, hypervigilance, and emotional numbness, this is something that is longer term. Get the baseline, listen in a non-judgmental way, and really try to think in terms of what are the immediate tools that you need to think about that might be helpful.
Yeah, it's a very different experience than working in some ways in a clinical capacity. I'm remembering when I was at the 9/11 memorial at the first anniversary, and mom approached me to help a young man tie his necktie. And it was obvious to me that his father had passed away in the attacks. And I remembered how my own father would tie my necktie as I stood behind this young man who didn't know how to tie his own tie. And I thought, this is just so important and moving. And so this is not a regular role for a mental health person. So we can stretch ourselves a bit and do what seem to be little things have a huge impact. And we had a saying that we still say, which is, don't just do something, stand there. And so sometimes we really want to help, of course, that's why we're in this field. And even Sigmund Freud, early on, for those of you who like psychoanalysis, cautioned against what he called excessive therapeutic zeal.
Mm-hmm. Good point. A question came up that I want to bring in, if you don't mind, Sandra. On the previous slide, we said that if we don't do some good coping, then risk increases. And the question is, risk of what? And so our focus of non-pathologizing is around avoiding or mitigating the development of a mental illness. So you want to expand on that, Sandra?
Right. So what we really want to make sure that we avoid the cascade of poor reactions that are expected that go into overdiagnosis, over medication, over treatment, or when we know that someone's increased level of stress puts them in sheer danger of really trying to do more than they can, overstretching, burning out. When we think in terms of responder community, it's especially important when we want to make sure that the stress that you have and you take it home and then are unable to engage with your own family may lead to loss of supports, loss of social network that you may have. If someone is not sleeping and starts to hyper focus on fixing the sleep, that may lead to excessive consumption of alcohol, excessive consumption or use of sedative hypnotics, all of them, of course, leading to even worse outcomes for the individual. So thinking really in terms of how do you shorten the space in which the person is at maximum distress. The faster you are able to remove them by providing the safety and various actions that promote the social connectedness, safety, engagement in the community, engagement in wellness. This is what we're really trying to get the person out of line of fire, quite literally, and start getting them to the point of recovery. I hope that makes sense.
Thank you. Yeah, I hope that helped as well. I'm going to jump in with a really quick example, a story that I can't resist talking about because I think it talks about this better than anything else that I've ever seen. Back in 1912, there was a horrific explosion that was caused by two ships passing each other and basically playing a game of who's going to move first, because they were both rushing and had tried to get out of the way of each other. And they were in the Narrows, in the area between the coast of Canada and the area around Halifax in Nova Scotia, the island of Nova Scotia, which is kind of a small area, why it's called the Narrows. But on one of the ships was benzene on the deck, which is like gasoline, and the hull was full of munitions going out to supply the war over in Europe. The explosion that was caused by the two ships coming together is the second largest next to Hiroshima. The cloud that it looks exactly like a nuclear cloud. The explosion was so huge, it completely blew half of Nova Scotia flat. There's nothing there. Sticks and people wandering around. Around 15,000 people were killed instantly. 300 were made blind. Many people had dismemberment because of all the glass that flew around and the wooden spikes. It was 1912. We didn't have tempered glass. It was a horrific disaster. And of course, they're an island. The help doesn't come for 24 hours, comes from by train from Massachusetts, nurses and doctors. But the night of the explosion, there's a blizzard, and so people who are already wandering around without any shelter, severely injured and without any help, are now getting frozen in the blizzard. It was just disaster upon disaster. It was really horrific. But I bring it up to say to you that there are but 3 books written about this, and they all write about the literally the psychosis of many people on the island. They describe women who are trying to feed dead children. They're describing men walking around completely naked. Their clothes was blown off and they had no idea that that's what happened. People were not cognizant. They couldn't make decisions. They couldn't figure out who they were. They describe a huge psychotic response in many of the survivors. But the really important point is that they note that as soon as help started to arrive, people started to get back to being able to function. And, Massachusetts had psych hospitals at the time. Nobody was sent back and hospitalized. There weren't psych medications that were being handled. And they talk very clearly about the fact that the severe, severe symptoms started to dissipate. To this day, a really interesting point is that Boston still gets its Christmas tree from Halifax in thanks for their response to this. But it's to me, it really says that you can see some very severe reactions in folks in a terrible acute traumatic stress event. But with good social supports, good coping, people can actually get back to functioning well. And the research is very, very consistent. We've got a flood of research after 9/11, then Hurricane Katrina, many other disasters since then, and mass violence incidents, that people, typically around 90% of impacted populations, will recover without any formal mental health treatment, without medications. And it only changes in a human caused with intent to harm incident, like a mass violence incident. The number drops down to about 80% of people who do better with good coping, good social supports, not needing formal mental health. And those who are at risk of developing a mental health problem often have other characteristics that may have made them more high risk. So it's something to remember in these immediate days. I like Sandra's example too. I worked for 3 years in the 9/11 response. I gave out lots of water and coffee and just said, hey, to people, and they started to talk. It wasn't mental healthy. We didn't describe ourselves as mental health providers. I still don't do that when I go in the field. I describe my role. Hey, we're working with Vibrant. We're here to support, see what people need, and try to help out. And people start talking and tell you what they need. So just another point, because we've gotten really good in the health and mental health professions of doing quick diagnoses and a treatment plan, right? And trying to fit that into what we've learned we need to do. And we're asking you to kind of put that on a shelf when you look at acute stress reactions. And as you heard Sandra say, is, if somebody had a mental illness before or some other kind of medication need, you want to go ahead and do that as you normally would. But to do something new and to start something new, there is a small base of literature that tells us that can actually be damaging. I had lots and lots of notes from firemen in Boston Marathon, where we helped there too. People writing notes and family members saying, they're really hyper, they can't sleep, and they look bipolar. But to start medications when they didn't have that before the event could be problematic. So just an example that I think is one that we can all learn from. Thanks,
Yeah,
Sandra.
and just to emphasize, to date, there are no good studies that demonstrate efficacy of medications as an intervention immediately post-disaster. Not talking about longer term, not long-term diagnosis, not long-term problems, but immediately in the acute aftermath of an event, there is no data to show that it is a good idea to start on anything new. So emphasizing once again, just what April is saying, usual interventions, usual care for usual problems. Avoid doing something that you wouldn't normally do. If you wouldn't normally advise someone to start on a new medication or do something you don't believe works for most people, don't recommend it post-disaster. Most of the time, that may not be a good idea.
Yeah.
So focus on knowing what the most useful and strength-based approaches are, engage people positively, give people meaning around the opportunities to engage and support their own community, to support their friends and family. That matters. Really helping to find meaning in the work and recovery efforts, developing appreciation and gratitude for really, how do you cope with the survival and the survivor's guilt when someone is lost in your community? You give meaning. You make sure people have a chance to build memorials, have a chance to commemorate the events in arts and culture. Really make sure there is meaningful longitudinal engagement to make sure that people don't feel like what has happened is utterly in vain, and that could really be life-changing for a lot of folks.
Yeah, likewise for medication, there's not evidence that it will prevent the development of problems. The only small exception there is IV steroids, which are not widely in use. And likewise for psychosocial interventions, there's not to my knowledge any specific intervention or therapy to administer broadly in the immediate aftermath of a disaster or crisis, though you will see a lot of people with all good intentions usually will be offering different interventions. And as Sander and April are saying, it's important to stick with best practices, which generally are restoring routines in community and providing supportive care.
Thank you, Grant. Yeah, the research is pretty clear on that. The guru of disaster research, Dr. Fran Norris, and one of her colleagues, Chris Kraniasti, write and have researched quite a bit about this. Probably the two largest studies are called 60,000 Disaster Victims Speak, Volume 1 and Volume 2. And as you can imagine, a study of 60,000 disaster victims tells us a lot. We're going to get a little bit to the dry part and not go through every single piece of this. We wanted this all together in slides in a PowerPoint so that you can have it and refer to it. There are 8 core actions to psychological first aid. They don't always go in the order that you'll see us present them in. A lot of it has to do with you're getting a sense of, what people are able to do at the time that you meet with them. We know very often, too, we sometimes only get to see people once, and we want to do what we can while we're with them. So we're going to go through the 8 core actions and give you a sense of what they are. Again, as you heard Sandra say, I'm sure you know this. I'm sure these are skills that you have and that you apply all the time. Again, we wanted to show you the structure of this and how it applies when we're working in the field after a disaster. We don't want to discount the fact that, of course, there may be people who are in need, and we'll talk about that. What are the red flags so that we can identify those kinds of folks as well? But we want to make sure that you have a sense that there are things that you can do that can help people to come, to be stabilized, to be grounded, and to get on a path of recovery. I'm always concerned if I think that somebody's kind of fallen off the path and are laying on the rocks, and nobody's helping them get anywhere. Everybody has their own timetable. We used to use this very nice, neat timeline about disaster recovery. And we know it just doesn't apply. Everybody does things in their own time, but we want to make sure at least that they are on a path. So here you see the 8 core actions. If you go to the next slide, Sandra, I put them in another slide so I could go through the first 4 to begin with.
And
again, they
before we go to that, I just wanted to address one of the questions because it's something that comes up. So I just want to put it to rest.
Right ahead. Yep.
There was a question that came up. What happens if someone is not sleeping? Should we consider using sleep medications? And the story I tell about that, and we tend to tell stories in these conversations because stories often stick better than research and facts, right? Ask why. What is happening? Don't jump into assumptions and don't jump to conclusions and make assumptions. Why is the person not sleeping? And talking about Afghan evacuees, when we worked with Grant, when we arrived to the first military base, we were immediately asked, can you please address sleep? Sleep is a problem. When we dug just a little bit, asked just a couple of people right in front of us and said, why are people not sleeping? We found out that the lights are too bright. Folks are waking up for morning prayer at times that is not convenient for most others in a large 500-person hall. The cubicles for families are too cramped. So when someone goes to the restroom, there are no lighting paths, so they wake the whole room up. That's why people are not sleeping. The large air conditioning units just outside of the thin tents were waking people up. We didn't need to write a single script after just making sure those basic things are addressed.
Right.
So,
And
in
by the
terms
way,
of
the small
why,
cubicles had no roofs. So there was a giant tent that was open to these lights. And then I think it was like at something like 6 a.m, someone would turn on all the lights,
Mm.
which made a very, very loud clicking noise. So,
so just really just think in
right,
terms
having
of,
said that, first do that assessment.
yeah, just do the assessment, do the usual thing you would do in your office. Would you ask before prescribing sedatives? You would. You would do the full assessment. You would try to understand what the person is facing before jumping to the interventions. So the disaster doesn't change that. Good care that is standard of care should be applied always.
Thank you so much. We could talk a lot about sleep, and there is a slide for you here to refer to when you need to help people with sleep issues. It is the number one thing that every single population has complained about after disasters. It's written in so many of the studies, and I have experienced myself, whether it's folks from a natural disaster, terrorist attacks, school shootings, child soldiers, Civil War. It's the number one complaint everybody comes up with. And so it's good to have a toolbox of ways that can help talk to people about how they can address that. And those, I hear this a lot from responders too. We need to know what we can do to help ourselves. I don't know about you, but sleep's an issue for me, and I use everything that I can, from, an eye mask to earbuds to music or audible books, anything you can to help with sleep. And there is a really nice slide that gives a lot of good information from our colleagues at the National Center for Mental Health. Contact and engagement is a core issue, obviously. How do you enter an environment that you may not be familiar with? You may not be from the community. You may not know people at all. You heard Sandra talk about, we sent out 98 different cadre members into 7 different military bases with Afghan guests who were in all different experiences of having left their country, from women with children to men trying to protect themselves and their families, to children who were pulled away from their homes along with their families, and everyone was struggling. Difficult place to walk into. So we want to make sure that we are doing what we call monitoring and surveillance. It's one of our responsibilities when we go into, whether you're going into tent or camp areas where people are in tents, or hotels where people may be housed, or whether you're going door to door. Make sure you know how you're going to introduce yourself in your role. You'll hear us say again, I know you all do good work. I'm sure you do great work. You're spending all this extra time trying to learn how to do these things and engage with your community. But people don't generally like somebody to come in and try to help them to feel better or to talk about how they're feeling. They don't like it. So it's not easy to do an type of engagement that will help people to open up to you. That's why if you're on a site, giving out coffee, water, blankets, doing concrete things is really important. First of all, it's very helpful. But you also need to make sure that you're on the lookout when you walk in somewhere, especially if you're going into the field where there are a lot of people who may have just come out of the situation, whatever the disaster is. They may need the bathroom, right? They may need a shower, a change of clothes. They're not going to be talking to you about how they feel. So we're not asking people how they feel. We're checking in to see, do they have what they need? So you want to be on the lookout for anybody who seems to be having over emotional response that they can't contain. If they're not calm, it might get other people upset or nervous, or children upset or nervous. And so you want to look around and see, who should I go over and check in with? Maybe who does need some help getting to the toilet? Who might need some water? Check in and make sure that everybody does have basics. You'll hear people say, don't ask me how I feel. I got to make sure I can take care of my kids. I got to find a place to sleep tonight. we go back to making sure that we're following Maslow's hierarchy and making sure that people have their basics. And that's a really good thing for us to kind of attach ourselves to, because those are easy, simple things that we can do. And they show a compassionate connection, a compassionate presence. When we go into communities and we start doing those basics, we usually get a good response from people. As we talked about before too, you want to make sure that you're respecting the culture, making sure that you know where you're allowed to be. Do you have permission to be there to talk to certain people? If not, ask them, can we sit for a minute? Do you want to walk? Is it okay that we have a bit of a chat and just check in and see how you're doing? You want to listen for what's going on. Are people having reactions that sound like what you're hearing from others? That kind of the normal things. If they're saying things that are really problematic and really bothering them, you kind of want to keep your ears up. How bothered are they by some of the symptoms that they're having? That's an important thing to recognize as well. So look at how are you going to engage? Remember, one thing I have to ask you to write this down if you don't remember it. Please, please, please introduce yourself and your role, right? So I might just be saying, hi, I'm April. I'm from Vibrant. We're a disaster response department and we're here to check in and see how people are doing. That's what kind of rolls off my tongue. It's not terribly explanatory, but it's general enough that people get the idea that we're here to help. You should know what it is that you're going to say. Half the time when we do a lot of these role plays, when we get to do a full-on training, about 50% of the people forget to introduce themselves. And we hear, it's one of the complaints that we hear from folks, is that they don't know who they're talking to. The person doesn't tell you who they are or what they're there for. They want to have a sense of safety, and they want to know who you are. We highly recommend name tags when you can do that. But if you don't have that, at least take the time to be human and make the connection. My name is, I'm from this particular place. This is what I'm here for. It really can help. And then again, check in with what are the kind of basics that people need, and look to see, do children need some support? Are they crying? Do they have toys? Is there a place for them to go to? The parents are always going to be concerned about kids. Everybody's upset when there's a kid screaming, or if there's an adult or someone that's crying and uncontrollable. How can you help to calm them, stabilize them, get to an area where they can have some privacy and calm down? So think about engagement. And as mental health and healthcare professionals, obviously, to pay attention to, please be fully present. We ask staff in the field not to be looking on their phones, right? Pay attention and be present with the person that you're with. And figure out what their concerns are. This is not going to be about us trying to diagnose people. What are they most concerned about? I'll bet if I asked you, let's use the chat and think about where we are and the time that we're in now. It's 2025. We're a social media country. What's the first thing that people ask us now? In almost every disaster where we've been in the field the past 2 years, it's the same issue. Put in the chat box if you think you know what that issue is. People walking into camps in post-disaster situations and asking us very specifically for something. Charging their phones. Somebody got it. Yeah, I just saw it go really quickly. It's absolutely, they need to charge their phones. There have been a couple of disasters where we've walked in and we set up tents, and all they are is like tons and tons of plugs and phone chargers in them. It's one of the first places people go. So these are the kinds of things that help you engage. People are going to be very happy to talk to you if you say, oh yeah, we've got a place for you to come and sit and use your phone and charge.
One thing that came up for me, and this may be getting slightly ahead, is that I have a close friend from college who lives in West LA, and he had a home that was destroyed in Ojai in 2017. And thankfully, I think he's okay now. But he and I were chatting, and one thing he said to me was navigating the fire insurance was really important, just to have pointers for that. And that is really useful for his mental health, because it's really hard to deal with things like that when you're displaced. And so that type of information and how to direct people to information is a very good psychological first aid skill to have. I'll share an interview that I did with him as well in the chat.
Giant. We've heard that actually all year long, Grant. It's a very good point. Thank you. When we send our staff into the field, we do try and get from the locals their list of resources so that we know where to refer people to. Again, it's a very helpful way to engage. One of the things to be really aware of, because sometimes we can lose sight of this, especially in a chaotic environment, if there are a lot of smells, because those are things that kind of stay with you the longest. They're the strongest thing. They stay with you the longest. Or if you're able to see the site of the disaster while you're trying to help people to stabilize and settle down, it just might not work. It's really important to be very aware. You know, in the Rhode Island club fire, they set up a family assistance center really close to where the club was because family members wanted to be near it. And the burning smells were so horrible. Like almost immediately, like an hour after they opened the family assistance center, they realized this wasn't a good idea. You want to be aware, as Sandra said before, just turning off the television, turning off social media, giving people the very specific instruction. That exposure is the change agent. It is the thing that can increase or not our acute stress responses, the level of exposure, the intensity of exposure, and the type of the exposure. So feel free to be very directive about explaining to people that decreasing their exposure and limiting their exposure is really the best thing to do. We know too from the research that directive instruction in crises is more helpful than giving people a lot of options. So many people have difficulty making choices in the acute aftermath of a traumatic event, and it's very, very helpful to give directive instruction about things that that can be helpful or not. You want to go ahead with the pre-existing conditions and safety and comfort issues?
Sure. And another thing to add, when we talk about reducing exposure, different people will cope differently. Dark humor will arise. People will use gallows humor to cope, and that's good. You want to make sure it's not traumatic to others. So especially if you're talking about responders, give people privacy, give an opportunity to be in an environment where you can exchange quiet comments and even laugh if you could. A close colleague who I'm the chief medical officer of a small not-for-profit called Languages of Care, and we focus on language equity. So our chief of staff lost her apartment in fires and is now looking for a place in LA. And her in-laws lost their house. They're 85 and now looking for an adult care facility to move into. And what they said to her, I thought is just something, talk about coping, right? Their comment was at 85, trying to kind of figure out what to do with themselves now. They said, well, we started thinking about moving to a retirement community. We just didn't know what to do with this stuff. Now we don't have to worry about it. It's amazing that they're able to say it, right? But it may not be for everyone. So creating spaces where a comment like this could be understood for what it is important and is a sign of healthy coping. But we want to make sure that we provide for safe environments to have these conversations. When we think
there was a question about survivor guilt if your house wasn't destroyed, and of course we expect that, and how do you deal with that is very individual. But part of it is service can be helpful, and part of it is just self-compassion and acknowledging that it's a normal feeling, and gratitude. And of course, there's lots of other dimensions to it, but survivor guilt is very common after a loss.
Yes, thank you. An important question for sure.
And as we talk, and yes, thank you, absolutely, Grant. I'm just trying to be mindful of the time as well. So I think April is gonna keep us on the straight and narrow.
Yeah.
So talking about safety and comfort, we want to make sure we inquire about pre-existing conditions. We need to be aware that people will need usual care, and because their lives don't stop because everything else has fallen apart. So there are going to be people who need injectable antipsychotics, who are going to need their diabetic meds, who are going to need medications for opioid use disorder. So all of those things must be available, because otherwise health will deteriorate. Emergency services will be even more taxed than they are already. So you want to really get a sense of who in the circle of people you are taking care of or engaging needs that sort of immediate help, and start preparing as early as you can. You also want to think in terms of obtaining really up-to-date information. Where else is the rest of the family? Thinking in terms of what sort of resources the person needs to be able to take care of their whole self, not just their individual self. And that means their chosen family, their birth family, all of those are really important. Thinking and considering how genuine you're going to be in these sorts of engagements is also very important. So practice some of the approaches that will work for you. Practice the introductions so it's not forgotten. That can make a really big difference about how well you're going to be able to engage and how effective you're going to be, because your window of opportunity oftentimes is quite small.
Mm.
When we think in terms of stabilization, the goal is to really reorient and ground people and give a sense of there is a next step. It's not up to this, shouldn't be up to the survivor to figure all of it out. A lot of it will need to be, but really thinking in terms of how do you give people a path through visual aids, through giving cues to what is happening next when they're standing in line waiting for services. You need to be expecting that there are going to be people who are going to be really quite emotional and struggling to contain their anxiety because there is so much happening all at once. So when we give people visual cues and safety and sense of, if you're going to wait here, someone will be coming and picking you to go to the next station, that can make a much bigger difference than just purging people in the room and say your name will be called, and then everyone is listening and everyone is panicking every time a similar name is called. So creating some of these systems is well worth the effort to make sure that you provide for stable, predictable environment. Watch out as you're engaging with a group of people who is particularly disoriented or confused, picking them out and focusing on offering them help can really demonstrate that you are paying attention, that you're going to get to the person in distress, calming the temperature in the room significantly, allowing for others to stay calmer and more focused on getting what needs to be done.
I will
Thinking in
suggest
terms
4
of
simple words,
able,
if I can jump in there, Sandra.
yeah, of
I
course.
will help you. I will help you. It can just help somebody to calm down so quickly. I hear responders argue with people and make excuses and try and explain. It doesn't help when somebody's panicked and hysterical or frantic or confused. Very simple, again, human connection. I will help you. I might not know what that looks like,
Exactly.
but it has an
Right.
immediate,
I don't know. I don't know. I have no idea what to do, but what I'm gonna do is stay with you until we figure it out together, or I will get you to the person who will take this conversation over and get you the answers you need. And never make promises you cannot keep. Be very clear if you don't know that I don't know, but I will make sure that I will physically walk with you, stay with you, get you to where you need to go. That can really help to engage people and calm down the situation at large.
I think
So
we can
if you
go
don't
on.
feel calm, I remember from the old inpatient psychiatry training, de-escalation techniques, act calm. If you don't feel calm, still act calm. So really makes a big difference how you present yourself, how you're able to engage folks. Give time before engagement, make eye contact, make sure people are aware of your presence, remain calm, respectful, and give help when needed. Make sure that the way you offer help feels fair. So make sure that a child and an elderly will be the first ones to be their needs are going to be addressed. It's going to give everyone a sense that there is some sort of order to things. These are small, tactful things that don't take a lot of time, but take effort to pay attention to and can help. Focus on clarifying misinformation. Primacy makes a very big difference in risk communications. So when someone hears the wrong thing, even if it is not intentional misinformation, it takes extra work to undo with that impression of incorrect information. So the crisis and risk communications is really a whole separate branch of knowledge that we strongly encourage you to pay attention to and learn more about. CDC has excellent content and full guides that vary from 300 pages to an index card, but there are some basics that you should know. Be first, be right, be credible, really high on that list. And when you share the information that is not correct, this is where the credible part comes into effect. Be the first one to identify that information is incorrect and correct it, because that gives you still the chance to capitalize on that primacy of you being the initial source of information that people trust. Explain that intense emotions can be expected and may occur in waves. These can catch up with you days, weeks, months later, years later. So make sure you understand if you are able to engage in a longer communication with the folks that you're helping, what is their prior trauma experience, what they have dealt with, are they okay, given that the situation may be familiar, are there things that they can do? And this goes into the information gathering portion where we
Thank you.
want
I'm
yeah,
going
go
to
ahead.
try and move us through a little bit so we can cover everything. The most important thing that I want to point out is, because I think we've been trained earlier to say that we have to process, that we have to talk about things. Information gathering in these sessions is not asking people to go through the detail of their trauma. We don't want to be asking, what did you see? What did you hear? What happened? You have to talk about this. We need the detail. We don't do that anymore. We have learned that the research tells us now that we can actually re-traumatize people. Now, that doesn't mean they're not going to be telling you anyway. In my experience, like 95% of the people, you say, hi, my name's April. I'm from Vibrant, here to check out, how you're doing and see how we can help. And the person will just start, they'll tell you everything. And if they do that, that's fine. That means they can tolerate it. But we don't go to doing what we used to call slicing the bologna, asking them to go through and tell us everything. We actually know we can decrease symptoms without even knowing what somebody's trauma is, right? We've learned from CBT, we can decrease symptoms, help them to get calm and stabilize, and we might not even know what the trauma is. So information really is about, what do they need right now? Who can we connect them to? Because we know social support is more important than any of that alphabet soup of therapies that we can do. Do they need the phone? Do they need to call someone? Can we help them to do that? Are they missing medications? How can we help them? That's really what information gathering is about, is getting from them what is their priority, right? I've heard this a couple of times, especially from folks who work with children. We start to explain things and give them all the detail, and, well, your mother's not going to be home because this and this and this happened. And, you ask the kid, what is it they want to know? Well, they wanted to know where their book bag was, or what time dinner is, and here we're talking about details that that's not where they are. Information gathering really is about helping to determine where the person is and what they might need at that moment, connecting them with social supports, or if they need another, referral, or if there are specific needs, especially for physical illness, a mental illness. If there's somebody who's a substance user, they need medications, or maybe they are in a crisis. This is the kind of information that we need to try and get from them. And then, of course, as you spend more time, as many of you talked about in the chat, are they expressing extreme feelings of guilt or shame? We're concerned about that. We're also concerned about people who are isolated. We want to make sure that they're not alone. In the early days, especially, it's important that people are together. And I know, 40% of the population are introverts, and we get people all the time who say, I don't want to talk to anybody. I don't want to be with any other people. And I usually say to them, great, there's a whole group of other people over there who don't want to talk to anybody either, go sit with them. We want to make sure that people are not alone and not isolated, because we're concerned that they can destabilize. And again, we want to make sure that we're paying attention to populations that may be at high risk. In the aftermath of Hurricane Sandy, New York response agencies missed folks who were not mobile, and thousands got stuck in apartments that they couldn't get out of because they couldn't walk down the steps and there was no electricity for elevators. It was a disaster within a disaster. There are all types of vulnerabilities that people have. So this is the kind of information gathering that we need to get from people. We need to find out what are their specific needs, and get that from those that are working with them, family members, and they themselves. This is the next 4 core actions. Practical assistance, we started talking about that. There are going to be all kinds of resources. You have developed a huge number of resources already. We highly recommend that those who go out in the field have some reference to either connecting with a case manager or having lists and fact sheets of those agencies that are providing support, whether it's, a $500 gift card from the American Red Cross so that they can buy groceries or pay for a hotel, to someone who will help them with insurance, to somebody who can, go back to wherever their house was and go through trying to take what they can. I mean, there are all types of very practical things that what people need help with. What we find is that people get overwhelmed with it all. And so in addition to getting help with some of those things, what we recommend for folks who are doing psychological first aid especially is to help people put a clear action plan together so that you can guide people through what do they need to do. And so that's usually getting a list from them of what things they do need to do, then helping them prioritize the list. And then, as we know from our colleagues who teach CBT, when can they do a certain thing? Put a date or a date and a time next to it, because then we know they're more likely to carry it out. And to, don't have to make the list a mile long. It can be 3 or 4 things for later or for tomorrow or for the next couple of days so that they don't get overwhelmed. It's similar to the problem-solving models that we use later on, but it's creating the simple action plans so that people can start to get the practical assistance that they need. Please do access additional resources and know that the 988 centers, there are 200 of them across the country. They usually are tied to your 211 systems, your local non-for-profits, your local government agencies. So 988 is not only a source of helping people with suicide and crisis intervention discussions, but they're also a tremendous, tremendous support in providing local resources for people who are in need. And there's no reason why not to refer that people just pick up the phone and call 988 or text 988. Can we go to the next slide, Sandra, please? In the early days of a disaster too, you'll see people, they tend to want to have individual support. It's harder for them to be in groups. people with kids tend to be in groups, and the kids tend to be in groups as well. But you'll see as they start to calm down and settle down, then they're much more likely to have group interactions that might help them, and they kind of help each other then, as we see that very, very common in most of the incidents that we've been responding to. Social support is, again, the number one thing. We're always trying to connect people with social supports so that they're not alone. And it seems to do better than anything else. People also respond to peer support. That usually happens a little bit later on. We don't often see that in the very early days, but more and more now, it is more acceptable for folks to go for peer supports rather than formal or professional mental health services. We have heard from many, many survivors that they didn't know that they would be experiencing these kinds of distress symptoms. Very often they have sleeplessness or stomach aches or headaches, and they don't assign it to the stress of the particular incident. So information on coping, it's really that psychoeducation about saying what are common responses to an acute traumatic stress incident. And these things are actually global. We may have different cultural expressions of distress, but the feelings themselves are universal, right? We have sadness, we have joy, we have confusion. These are all human reactions to different situations. So when we say to people, it's really common to have a headache or sleep problems, it doesn't mean you're developing PTSD. What we know from the research is that people who think they're doing poorly do worse. So we want to kind of not minimize, but allow people to understand that it's actually expected that they may have some of these reactions, so they don't feel like, oh, what's wrong with me? I'm not dealing with this. Especially as they go through the next couple of weeks, they think like the next day they should be okay. We have to say, no, your body's been shocked. You know, it's going to take some time to be kind to yourself. Somebody had said that earlier. I love that kind of instruction. We give them basic information about what it helps us to cope best. We know from literature that body movement is really helpful, but we want do no harm models, right? We don't want to be telling people to do heavy exercise. So we do breathing, stretching, and walking. These are the 3 do no harm exercises that our colleagues at the National Center for PTSD tell us are really helpful. If you don't know models of grounding and breathing, you should learn them. They're all over the internet. This is a simple one. I like to add it here because it's good that kids can think about a box. It's good to have an image. And you do a very simple breathing exercise. I always do it with people. Do it with me now if you feel like it. You take a deep breath in to the count of 4. Hold it for 4 seconds. 2, 3, 4. Fully release to the count of 4. And then hold for 4 seconds before you take the next breath. 3, 4. And then you start over again, and you do it at least 3 times. You'll see people immediately start to calm. If you don't like this model, that's fine. There's the 3-5-7 model. They're all different types of breathing exercises. You should know 1 or 2 and go through them with people so that they know what to do. But again, we know from Bessel van der Kolk, the traumatic stress specialist, that moving the body gets stress hormones out, especially for those of us who are sitting and working virtual a lot, doing different types of movements with your upper body, forward, backwards, moving stress hormones out of your body. You can do these sitting or standing. I wrote the one down here that you can do even if you're sitting, and do these at different points during the day. Just make circles with your hips, move them around, right? Put your hands on your hips and move them around. Inhaling while you arch your back, and then releasing as you move forward. Any kind of body movement that isn't too strenuous, mostly stretching. Many of you do yoga. There's trauma yoga specifically, but stretching is a tremendous help. So teaching those that you're with to take a walk with me. Let's do some stretching. Let's do some breathing. It will help you feel better. It will get rid of some of the stress. These are simple things. I always think that people are going to say, no, I'm not doing that. Everybody does it. I even do it with people on the phone, and I think they're going to hang up on me. And what do I hear on the other end? You know, they always do it. So we know that it's helpful. We know that it works. We know that deep breathing can stop a panic attack, right? You can't have a panic attack and deep breathe at the same time. This is a good thing to tell people. I taught a client how to dance. I love that one. Anything to move your body in a way that's not too strenuous. We do know that picking up heavy weights can possibly damage the muscles. When there's adrenaline in the muscles, it can cause a little bit of a problem. So again, do no harm, simple, gentle, stretching, breathing, simple things, walking. This is the sleep slide that I promised you. Different ways to help people to learn ways to address sleep problems. We also have the mobile app for the CBT, the Cognitive Behavioral Therapy Coach, which is full of different kinds of exercises and pieces of information like this, in addition to some very specific CBT exercises. As Dr. Koyfman said before, the Center for Traumatic Stress from the Uniformed Services University has an incredible array of documents, fact sheets, information sheets. They're downloadable, they're for the public domain, they're incredibly informative. You can use them yourself, you can share them with people that you're in touch with. Chair yoga is wonderful, you're right.
And also, it's worth pointing out they're available in multiple languages. Our website, Languages of Care, has quite a few of different languages, and we've collated some of the core documents. I'll put the link to our documents folder as well. But the good news with advent of the technology, the ChatGPT and similar tools will produce more than adequate translations, vast majority of the time these days. So you don't really need to chase a specific document in specific language. Our team has done the vetting, and what we're realizing really, the automation is reaching for most common languages, is reaching really high level of accuracy. Expedience here is gonna beat absolute precise accuracy. But if you'd like to find a specific document in specific language, I'm gonna add the link here as well.
Thanks, Sandra. It's such a great resource to have, as well as the next one I'm gonna ask you to talk about.
Thanks. So the important thing that also came to be appreciated more during COVID is that healthcare providers are not great about setting aside the time to take care of themselves. So at least one of the groups that now the backbone of this network is handled by Vibrant as well, is the physician support hotline. There are physicians, psychiatrists who are available to talk to folks. You can just call and talk if you're a healthcare provider yourself. As I was pointing out, it is useful to have a battle buddy. It is useful to have someone in the space that does similar or same work that you do, so you can appreciate the perspective, you can appreciate the stressors, where just earlier today, I was talking to someone who's a specialist in occupational therapy, and I misspoke, and I said, and it would be great if you're able to do some PT with our clients. And she kind of gave me a gentle glare and said, OT, not PT. So just realizing that these things matter when it is such a huge part of one's identity and professional service is really important. So you want to be extra sensitive and pay attention when someone says what they do, as I didn't. We want to make sure people are aware that there are peer support groups that are able to engage, and you can speak the same language when you can refer to some of the professional experiences.
Question, Sandra, is the physician support line available to non-physician mental health workers?
I don't know their latest sort of rules of engagement. In the beginning, they were specifically for healthcare providers, but I think they also will have resources for others. If you were to call and ask for other peer support organizations, I believe they have some that information as well. In general, you should also know that disaster distress hotline that is part of 988 service is also able to provide a great deal of information and resources. But specifically for decision support hotline, I don't know if they've expanded to other groups as well.
Thank you. We'll link back around, but we have the other resource information on slides for you to refer to as well. I always think that we really shouldn't be walking away with survivors without giving them some connection to other resources, whether it's just 988 or the disaster distress line, or your local crisis centers, your local mental health centers, your local healthcare clinics, which also offer an array of services. You know, to be able to give them any kind of connection. We just don't want to leave them without anything. The other thing to know that I find as we go through the country is a lot of people don't know that a lot of money usually comes into the particular area, the impacted area, after a disaster. When a federal declaration is made, money will come into the healthcare centers, they'll come into the mental health commissioner's office, and there are opportunities for local agencies to become providers that are paid for by these federal funds. So it's always important to know, you know, who are your leads in the agencies that you work with that can connect with your local emergency managers, your state emergency managers, the folks who are writing these grants about, you know, getting monies to come in to make all of you whole as you spend time responding to the disaster, right? You're taking care of your regular caseloads and you're also taking on more disasters. The idea of these grants is so that you guys are able to continue using your regular funding to pay for the patients that you would normally see every day, and then additional funding from the feds to pay for disaster work that you may be picking up and people that you may be hiring extra to handle the additional services that you're providing as a result of the disaster. So it's just something to know if you don't know already, to connect with your local emergency managers, your state commissioners, folks who are aware of these funds that will be coming through the state, because you've already had, I think, 2 or 3 declarations. So we know that individual assistance, somebody mentioned before, will be coming in so folks can fill out applications for their homes, but agencies will also have opportunity to apply for funds to help to continue to support disaster survivors. The topics that we just wanted you to be aware of, you've heard Sandra say this before, you want to check for different things that may be going on a regular basis. You know, we know that folks are needing certain medications. We know domestic violence, unfortunately, doesn't disappear. As a matter of fact, it usually increases depending on particular incidences, which is really interesting. In mass violence incidents, domestic violence does increase. And in some large-scale disasters, which this obviously will be considered, we've often seen numbers of calls to the domestic violence hotline increase dramatically. These are things we need to be aware of as health and mental health practitioners to be able to do our usual assessment and ask people about their levels of safety. Unfortunately, too, we see opportunities that some people take to engage in either taking a child away from its mother. It's often somebody that they know are doing this in disasters. This is really common. After Hurricane Katrina, one of my colleagues spent 3 years trying to identify the 39,000 foster care children and children who were in other types of institutional care, because there were so many who were taken and moved around. So again, we need to know who are the community resources that we should be referring the adults to who are concerned about these issues or who express such a need. And we don't know what's happening to folks. Somebody mentioned earlier, folks who may have been in congregate care or group homes, and they're homeless as well. And some of them may struggle. Now, the research is really interesting around folks with serious and persistent mental illness. Many of them, about 50%, report that they tend to actually do well because, you know, what could be more traumatic than having schizophrenia, right? They've learned to cope. They've got social support systems. They've got care systems of care that they rely on, and they've learned to do things to deal with their own trauma. Another 50% may be at higher risk because they don't have such good support systems of care, or maybe just aren't stabilized. And so we see a real mix. The same thing with the elderly adult population. We see about 50% of these folks are well and healthy. Maybe they are retired, so they have a lot of time. They can do something and offer to help in the response. Others, especially those with mobilization issues or chronic physical problems, are at higher risk. So those are the folks we're concerned about. One of these sheets that kind of was one of the references we saw from the folks at the Center for Traumatic Stress. These are things you can download, you can copy them off, share with your clients, leave in your waiting rooms for folks who are struggling. Just some ways to help them to deal with difficult problems like alcohol and substance misuse at the time of a disaster. We want to try and give people some, ways to try and address these things. Of course, we're not going to change everything in the immediate aftermath of a disaster, but you don't want to be left without giving them some ways of trying to help to deal with these issues. The red flags are things that we want you to be aware of, because when you see these, one or two of them alone, doesn't mean that somebody's necessarily developing a mental health problem. But when you see them together, it's very likely they're already diagnosed or diagnosable. So nightmares and flashbacks are very common in the early days. You hear this from veterans all the time. They feel like they're there. They can smell, they can see things going on right in front of them during the day when they're trying to do other things, and it's disruptive. Lots of people also in the early days talking about nightmares. These often do dissipate unless somebody, again, does go on to develop something like PTSD, but you'll hear people talk about these a lot in the early days. So again, a little red flag should go off in your head, but you want to then check for other kinds of problems. Hypervigilance is another serious symptom. Unfortunately, this one tends to not go away so quickly or so easily. For some people, it stays with them after a traumatic event their whole life. So while it is a red flag by itself, it's not indicative of somebody developing a mental health problem. Extreme avoidance, not thinking about or talking about the event, going 20 miles out of their way so they don't have to go past the area where their child died or where this particular trauma happened, cutting off everybody that they knew at the time of the event, not talking to it about anybody at all, completely avoidance. Again, extreme avoidance, we're certainly concerned about. And then when you add that to numbness or dissociation, we're very concerned. Those top four things together means that somebody probably has PTSD. Numbness and dissociation is really common in the first couple of days. And I'm sure you've heard people say this, oh, it's like I was watching a movie. It's like I was outside myself. That's really common. But when it continues, it can become very problematic. When you do dissociate in the immediate aftermath of a trauma and you continue to do that, you get really good at it. And again, people then dissociate. The problem with not feeling is then you don't feel. You can't relate to people. You don't have not only the pain of the trauma, but you don't have joy. That can lead to substance abuse and other issues. So we're very concerned when we see the top four areas here together. Those are key indicators of PTSD. And then we see other common things that we're concerned about because they do also add to isolation. They can add to suicidality, especially social isolation and withdrawal. What we know from the research is social support helps the most, social isolation is really, really unhelpful, and can lead people to having difficulty. Of course, anger and violence are never tolerated. We need to identify people who are using anger as a way of like staying away from other types of feelings, and violence is not tolerated either. So we go to CBT to help move them off of those things as much as possible. And we talked about before the 10 or 20% of people, depending on the disaster, who are at higher risk of developing a mental health problem, usually have at least one or more of these risk factors. And I'm sure you're familiar with these. There are things that can really inhibit people from being able to function well, to have relationship, to have any functioning at work, at home, to have any joy in their lives anymore. And so we want to make sure that we're checking to see, what's been going on before the event, and that they have the supports that they need so that they don't go on to develop a mental health problem. Dissociation is a brain response. I'm not sure what you mean by that, Jennifer. They're all brain responses, really. Yeah. Next slide, please, Sander. Ah, the one thing nobody responders don't want to talk about, right? You're on mute, Sander.
Sorry. I just wanted to give you a breath.
Thank
So,
you.
so self-care for responders, having April take a breath. These things need to happen and often need to be prompted by someone else. It is so easy to be overstretched, overengaged, and you're not able to perform as well as you can and should, oftentimes, if you're acting in professional capacity. If you're a volunteer, of course, there are other volunteers around you to help you cope and tap you out. So really think in terms of what do I need to do to be most helpful and most effective. Not taking the time to rest will decrease your ability to be good at caring. So that decrease in care will come through and you will be less helpful, and you may end up causing more harm than good. Others working around the clock, it doesn't mean that you are seeing the whole picture. People may be taking breaks, taking care of themselves when you're not. So you don't want to kind of create these false storylines in your own mind. As high-performing individuals, those who are doing professional work, we often thrive in hard work, difficult environments, and oftentimes the badge of honor is putting less effort to do what others have to work really hard on. Well, that is not going to be something that is going to save you in a disaster setting. So you really need to put hard work into taking care of yourself. If you don't do yoga, if you don't do sports, if you don't do basic things that help everyone, that may be a red flag for you as a responder. Find what works for you and do it. It's worth it, it's necessary, and it will keep you well. Having unrealistic lists and goals can be really quite harmful as well. So that drives folks to go volunteer on their own without engaging with an organization because they feel that they can get done more. That is really problematic in so many ways. The one thing that you want to avoid at all costs is don't become another person that needs care in the field. If you're not prepared, if you're not taking care of yourself, you're putting yourself at risk and you're going to deprive others from the resources that they could be using.
Yeah, and remember that if you didn't have some kind of your own reactions, you wouldn't be human. So to think that just because we're a healthcare professional or a mental health professional or a responder of some kind that we shouldn't feel things is unrealistic. And it does shut us down. It's why we've seen such high levels of divorce and substance use in our traditional first responder populations. It's because they shut down, right? And would not feel and would not be able to get back to their lives. So really we need to recognize if we didn't feel things, we wouldn't be human, and that there are things that we can do to release the stress and the distress that we feel from being engaged with victims and survivors in these situations. We do think that agencies can do things to help with management as well. We rotate folks so that they're moved from the most highly exposed assignments. Now, excuse my description here, it may be a little disturbing, but you should not be a responder who's spending like every day the next couple of months working with burn victims who may really have a very gruesome presentation, smell, things that are really, they'll get through the blood-brain barrier and disturb you in a lot of different ways that might make it difficult to have to do this every day all the time. So there are things that can be done on an agency level to make sure that you're not the only one who's dealing with the most traumatized or the most difficult cases. Again, remember, exposure is the thing that can really lead us to the development of a problem. We've gotten away from supervision and case conferencing. I hope that many of you are going to write in the chat box, no, that's not true. We do that all the time. I'd love to see that, but too often I speak to people who say, supervision, I don't get supervision. I have a supervisor, but basically they tell me when I've done something wrong. Case conferences can be so helpful. But also it's up to us to bring to supervisors or colleagues when we are having some difficulty. If you can bring it to your buddy and they can help you, that's great too. But in the workplace, if there's something that you need help with, you should be asking for, and in a sense, demanding that you have supervision so that you can deal with difficult cases. And that does include cases that make you upset, bring you nightmares, have things that you can't resolve on your own. So that supervisors can help with this. And do regular, stress management practices. We have something at Vibrant that we call pacing programs. We give everybody 10 to 15 minutes between meetings so that there aren't back-to-back meetings and people actually have a chance to have a bio break. We talk about having a buddy. You've heard Sandra say this about he and Grant. I have a buddy who's out in Hawaii. Doesn't matter. We can text, we can chat. Different ways to connect with people so that you can get help. These things work only if you use them. So it is going to be up to you to implement them. We always feel like we're not doing enough in this profession. Healthcare workers are some of the most extraordinary people in the entire world and do things that like nobody else will do. I don't know what messaging other than doing some CBT and some thought insertion and thought messaging that helps you to recognize that you are enough, that you're doing enough, and that you deserve to take breaks. We do mandate people to take breaks and to take time off. They argue with us all the time, but you just can't. I tell them it's not a discussion. It's basically that's time when I get really mean and I say this is not a request. And it's not a discussion. You're off. I'd have people working, used to run a psych hospital. They'd be clocked by a patient who was really psychotic and, whacked them in the head or knocked them to the floor. And they'd get up and want to go back right away to start working with patients. I'd be like, 15 minutes, you're off. And they'd be like, no, I have patients I have to take care of. I hear this from healthcare workers all the time. So, it's up to us managers, supervisors, but individuals enough to say, I need 10 minutes. I need 15 minutes. I am going to take my break. I know it's really busy. And we know from the research that we function much better when we do take breaks. Everybody after a disaster talks about gaining weight, about too much caffeine. You guys know what to do to try and take care of yourself. When if I'm a team leader in the field, if we go into some place where there's a lot of alcohol, I will automatically just order seltzer bottles for the whole table. And I make a rule to my team that nobody stays in the bar while the rest of us leave and that nobody has more than 2 drinks. To me, 2 drinks is a lot, but I really get yelled at if I say, no drinking. But I set these rules and I always think the people are going to be, because they're all adults, right? They're going to be like, yeah, right, honey, I'm not listening to you. They always respond. We might get somebody who fights about leaving the bar when they really want to hang there. But when you kind of set the structure, it works. Again, I've been in the field for 30 years. I've been in some tough situations with folks folks I don't know. In the past few years working at Vibrant, I know most of the cadre, but I've been thrown into situations mostly where I don't know people and I'm the team leader and I make these rules and they follow them. So there are things that we can do to set up self-care for the responders and help each other. And be aware that going home is usually a messy, messy situation. We get a lot of meaning and purpose out of this work. A lot of people refuse to return to their regular jobs. Some of them fight with their families. Others start drinking or close themselves up in their room and don't talk to anybody. This is something that's problematic. And so we want to make sure we always check in with people and do some group debriefings and provide some support and follow on for about 2 weeks after people return home. If they've had trouble in the field, we'll follow them on for longer than 2 weeks to make sure that they're stabilized. Sometimes they do need to be referred to talk to somebody, especially if they really have broken down in the field. I worked with somebody after Katrina who completely lost her ability to think clearly, to finish a sentence. She couldn't lead her team. She was a team leader. I got sent in to take her home. I had to pack for her. I had to take her by the hand and put her in the car. I had to call her husband and say, you got to meet her at the other end. This is a highly functional mental health professional. Got completely overwhelmed by the deaths and the destruction that she saw in the area where she was attending to team members after Hurricane Katrina. And it's happened in other situations as well. So self-care is something that can really mitigate that from happening. Yeah, your worldview changes. It's true. Some people don't trust anymore. Some people think that bad things are always going to happen. People have all different types of worldview changes, Alyssa, when they don't have support or feel like they're overwhelmed. Again, 988 is a key resource. There are 12,000, I think, crisis counselors that answer the phones at this time. They spend about 120 hours before they're allowed to pick up the first call. They're trained in crisis intervention as well as suicide prevention. Most of the calls are crisis intervention. Only about 1 or 2% are suicide. And so we want people to feel comfortable to pick up the phone. The Disaster Distress Helpline is a sub-network of 988, so you actually get the same crisis centers most of the time who are answering the phones, but some people just don't like to call the suicide and crisis line after a disaster. And so there is an independent number here, the 1-800-985-5990. And you can also text, and there's also a Spanish version. If you call the 5990, you can hit 2 and you'll get a Spanish speaker directly. Go ahead, Sandra. This is the Spanish access to, direct Spanish access to Linnaeus Paz, who answers the disaster distress line in Spanish. Thank you, Sandra.
Another good resource to use, and there are a number of tools from U.S. Department of Veterans Affairs. The PFA Mobile is a great app. You can load it on your phone. You can recommend others to do so as well. And it covers a great number of the resources and tools that we talked about, talking about the basic principles of psychological first aid. There is also a great app in the same library of U.S. Department of Veterans Affairs, CBTI for sleep. And it really helps to address some of the basic tools. I frequently recommend it to my patients during the appointment. I will make them download the tool and we'll go through some of the tools in the toolkit, and they're incredibly helpful and quite portable. So strongly encourage you to take a look as well. I think we're on slide 44, so we'll pause and hang out.
Thank you, Sandra. I did have a Mark D slide in here. Did we miss it?
So I think I never received the latest final version. So why don't we spend a moment and talk about Mark D? I think
Okay,
that's
I'm
a
gonna
great.
Do
put
you
it
want to
in
maybe
there.
open the link and then share that
Yeah.
screen?
So let me just do that.
Just put it in the chat
Yep.
as well.
I'll
Thank
do,
you.
Yep. So this is the
we'll
model
go-
for adaptive response to complex cyclical disasters. Sandra and I are on a committee for disaster trauma and global health with the group for the advancement of psychiatry. And in 2020, as the pandemic was picking up and a round of wildfires was going through California at that time, we realized we needed a more complex model to capture all these different disasters. We worked with Vibrant and Decision Point systems and developed this model, which Sandra and April can tell you about a bit.
Thanks so much, Grant.
Yeah, so the goal of the model is to really think about if we can understand what happens, what's the typical expected structure of disasters, what comes next. If we are able to see that on a piece of paper, hopefully we can see that in the way we communicate, in the way we engage with the community, in the way we can predict some of the needs, and we can help decision makers in the community as well. So the way the model is structured on the website, if you go to the Mark D link that is in the chat, you will see you can scroll up and down. You can use different sections of the model to suit your needs and think in terms of plugging in what is the reality around you. We left some of the basic structure quite open to make sure it is usable in different circumstances. We talk about common phases of disasters, and of course, it's not linear. Many things can happen out of order, but in general, we anticipate there is the immediate impact, there is a period of adaptation, and hopefully growth and recovery. What we also wanted to really think and capture is multiple disasters can happen and overlap often. You need to understand what are the structural problems in the community that may be impacted by fires and may have poverty or maybe a food desert or any other thing that may be long lasting, making the risk factors specific and different for a particular community. Who are the people that you're going to be working with? What are the phases of disasters? So the large groups of survivors, community leaders, and responders are easy to categorize, and of course, are not all inclusive. And there are going to be their families in the background. There are going to be their kids. Many of the individuals may be both community leaders and responders and survivors. So thinking, how do you really address how they will deal with the distress on their own accord? Where is the adaptive green band where we are at our best under the worst circumstances, and what can happen if we are over or under regulated is what we're trying to call out. Can we think and see and anticipate where the different phases will impact different groups differently? What is the community leader is going to be doing in the adaptation phase, and how they can get ahead of the needs of the community when the community reaches growth and recovery stage? So reading this chart in different verticals and horizontal ways can help you to see and anticipate and function better in your respective roles. What are the underlying risks and resources that your community may have? And at the end of the day, how many resources does your community have to cope with multiple overlapping disasters where the impact of one may overlap with the recovery of the other, and how all of that may compete for one's attention? So this is the goal of the model. There is much more complexity in any disaster. And the old saying, disaster community, if you've been to one disaster, you've only been to one disaster. It's difficult to generalize, but at least to have a framework so you don't have to reinvent the wheel is the reason we put this tool together, and really encourage you to use and think how this could serve your goals as well.
I know it's a lot of information. We talked fast. It's too much, but we know how valuable everybody's time is and how short it is. So we tried to pack a lot in, but I know Alyssa said she will be sharing the slides and the recording, and I hope you get a chance to pull from it whatever else you might need. And thank you so much for paying attention, for being here, and for the work that you're doing within all your communities. We so appreciate all of you.
Thank you, April, Sandra, Grant, for your wisdom, your deep experience, your rich resources. We will share them out. Thank you, everyone, for your engagement. And we hope to stay connected. We did want to provide the link to those webinars again. And we have a class for young adults who are coping with the climate crisis and feeling a lot of doom and distress. And so we're adding psychological first aid to the class now, you know, some of the basics and the grounding from what we've learned from you over the last week. And so we just want to emphasize that we are all a network in our different ways. I saw your call for volunteers for Vibrant. That's very exciting. And so many experts and professionals have joined today and also have resources to offer. So we'll find a way to also share resources and be a hub for upcoming opportunities for training. So have a wonderful night, everyone, and we'll stay connected. Thank you so much.
Thanks
Thank
for
you.
inviting us.
Appreciate you all.